mini lecture is going to be on benign skin lesions as well as information on dermatitis. The first thing we're going to talk about is actinic keratosis, and this is the most common precancerous skin lesion found in light-skinned patients. So we talked in the past about patients with that Celtic background with skin cancers. So the Irish, the Scottish, the English, people with light hair and red hair, blue-eyed, freckles easy. Those are the type of people we're talking about again with this. These are found on sun-exposed areas of the skin that have been damaged from cumulative sun exposure. So the head, the neck, the forearms, and the hands. And they are considered to be a potential premalignant lesion that can lead to squamous cell carcinoma. The squamous cell carcinoma in these patients, the actinic keratosis is associated with about 1 to 10% risk of progression to squamous cell over 10 years if it is untreated. There's estimates of progression to squamous cell that vary widely, so anywhere from 0.25% up to 20%. And another estimate is that only about 1 in 1,000 of these lesions can progress to squamous cell. So aggressive treatment of the premalignant lesions does remain kind of controversial, but I still think that it needs to be looked at by a dermatologist to confirm that it is not anything out of the norm. The most susceptible individuals, as I said, are those fair-skinned too, but they've also noticed that these are more predominant in older adults at 50 years old, similar to the previous lecture we talked about with the skin cancers. And they've also seen an increased risk of developing actinic keratosis with patients who have had renal transplants, and they're not really sure why this does occur. When you look at these lesions, just to give you an idea, they're rough and scaly, and sometimes the patient complains that they're itching and they're tender and they have stinging, but they're mostly concerned about the cosmetic appearance than anything. When we're looking at these and we're treating them, there's a couple different options for treatment. And one, if it's a very mild actinic keratosis, is you can do watchful waiting with no treatment. But there's also the option to treat with some different medications. Topical applications of 5-FU creams such as Effidex and Carac can eradicate the actinic keratosis because 5-FU is selective for affecting only sun-damaged cells. This cream is usually applied to the lesion twice a day for about 2 weeks. The eyelids, the folds of the nose, and the lips should be avoided, and it usually takes about maybe 2 to 4 weeks for the replication of the epidermal and the adnexal cells to occur. Patients that are treated with this sometimes have some nasty side effects. It leaves their skin raw and tender and red, and you have to encourage them that they do need to keep on doing this, and they have to be very careful not to over-treat them. There's a picture on the module section of this lecture where if you go all the way down to the bottom, you'll see a picture of a patient of mine who was treated for 28 days with 5-FU. And she actually had severe burns to her face and had to be treated for those burns. So you have to be very careful. Some evidence does show that Retin-A, when used in combination with 5-FU, can increase the effectiveness and the shortness of the therapy. But the 5-FU is used a lot for the thin lesions, particularly the ones on the face and the scalp and the back of the hands. There's also cryosurgery with liquid nitrogen that does give you about a 69 to 99% cure rate. And there's also imiquimod, 5% cream that can be used on the face and scalp, and that's applied for 3 times a day for 5 weeks. So that's another option that's available. And then photodynamic therapy, which usually is a light sensitizing compound, and that does uniquely accumulate in the actinic keratosis cells, and it deactivates them. So once inside the cells, it is really converted to a potent photosensitizer, and with exposure to light of an appropriate wavelength, then these oxygen-free radicals are generated, and then cell death does result from those, taking the whole keratosis away. But if you are suspicious about the features, then you need to refer to dermatology for an excision and biopsy. And this is a really good picture that I can show you of the actinic keratosis, and you can see here where there's that rough and scaly appearance. It's kind of got a yellowish appearance to it, and if you would try to flake it, it will come off. Another benign lesion that we're looking at is seborrheic keratosis, and these are they're kind of like a benign warty appearing growth that's commonly seen in the older adults. These are usually found on the trunk, but they can also be seen on the hands and the face. And once again, they also develop due to sun exposure of the unprotected areas. The tendency to develop these is an autosomal dominant trait, and it's extremely common. It's been found in about 88% of persons older than 65, and 50% often develop 10 or more lesions. So these begin as a slightly raised, skin-colored or light brown spot, and then they take on a rough, warty appearance as they start to grow, and then they eventually become darker and turn black, and they almost look like a waxy substance that's stuck on the skin. And many people try to scrape them off, but they're not able to do that. These originate from the horny layer of the epidermis and are the result of benign proliferation of the immature keratinocytes. So when you're looking at these lesions, you may see that they have these horny cysts on their surface. These are also epidermal tumors, but they are not considered malignant or pre-malignant because they don't undergo that transformation like the cancerous lesions do. So sometimes they can be confused with melanomas, and we'll look at them and be concerned because of that darkening and the thickening of the skin in that area. And this is kind of what they look like. So you can see that when you look at a melanoma, it has irregular borders just like this does. So it's a little concerning. So if you ever are suspicious, just go ahead and send your patient out to be evaluated. Okay, let's talk a little bit now about the dermatitises, atopic dermatitis as well as seborrheic and contact. So we're going to look first at the atopic dermatitis, which is also considered to be an eczema, an atopic eczema. And it is a more general term that's often used to describe the skin of an erythematous and inflamed appearance. Currently, the terms eczema and dermatitis are used synonymously, so you may hear someone say, I have dermatitis or I have eczema, but the term eczematous rash may be also helpful by diagnostically and therapeutically classifying it into two of those categories. So we can look at either categorizing it into contact or into atopic, and we'll look at both of those. So this is a constitutional and an inherited reaction, which usually begins in infancy. And children born to older women are more likely to develop eczema than children born to younger women. And for unknown reasons, the prevalence of atopic dermatitis has been on the rise in the past 30 years. They do look at it as being associated with elevated serum immunoglobulin E levels, which is allergy levels, as well as allergic rhinitis and asthma. So there is a link there between the atopic dermatitis and those. Now, when my children were younger, they were both diagnosed with asthma, and they both had to be hospitalized because of atopic eczema. And there was a definite correlation there. Now, they did outgrow both of those things, but when they were 1 and 2 years old, they had significant issues with this going on. And they talk about it as being, having that family history of a triad. It's called the atopic triad. And that triad is that asthma, allergic rhinitis, and the eczema. So that's what they call that triad. And it's been proposed that individuals with any of these three conditions have preferential production of that IgE, and that the presence of those antibodies should be a mandatory criteria for diagnosing atopic dermatitis. However, only doing that diagnostic test really only establishes the diagnosis of an atopic syndrome. So it doesn't really give you a definitive diagnosis of atopic dermatitis. So any patient with a history of hives, hay fever, or rashes should also be considered to have some type of an atopic history. One of the big problems with these patients is that they itch a lot. They have itchier skin, yet what seems to be unique about the atopic patient's skin is it's hypersensitive. Many factors that do not make um, will not make that person feel itchy, but the atopic patients are known to itch seconds after they get some type of a stressful event. And this type of reaction is thought to be caused by some type of neuropeptide induced vasodilatation, and that makes the skin temperature rise and then causes the erythema to occur. So these symptoms can be triggered and can be exacerbated not only by between the genetic predisposition, but also that environmental factor that is occurring. The excessive hot or cold climates or excessively dry or moist environments are suitable for the setting to have this type of atopic process. So when you think about the common triggers for this, excessive bathing, someone who's constantly putting deodorant on, hand washing, um, licking their lips, they're sweating, they're swimming, they may be using a lot of cosmetics, smoking. So there's a lot of different things that can trigger this to occur. And this is a good picture of atopic dermatitis. It's characterized by an extremely low threshold of itching, as I said before, but you also can see that the patient has like acute lesions that are excoriated. They may have maculopapular appearance and they may be inflamed. When they're in childhood, they could be oozing and crusting, which is characterized by that erythema. In adults, though, usually it presents more with symmetrical lesions that are crusting and excoriated. So in these early stages, the lesion may be red, it may be papulovesicular, it may be edematous, it may be weeping, and then later that rash becomes crusted and scaly and thick. And the classic locations for these lesions correspond to the areas where they're rubbing and they're scratching. And so, how are we going to treat these patients? One of the things that we do is we're looking at diagnostic testing. They're not usually helpful in the diagnosis of atopic dermatitis, but they can be helpful in ruling out other disorders. So, thinking about doing the RAS test, doing an IgE test, that's really about all you can do. And how are we going to treat them? Well, looking at the management is really to control those signs and symptoms because there's no cure for this at all. As we move on to contact dermatitis, this is a common condition categorized either by an irritant dermatitis or by an allergic dermatitis. So, although both of these conditions can have similar presentations, the etiology is what differentiates those two from each other. So, the allergic contact dermatitis is an immunological mediated response, and the irritant is the result of a repeated insult to the skin from some type of an irritant or some type of a detergent type substance. So these patients can present with many different things that they're feeling, and they may think they're allergic to they may have allergies to plants, to poison ivy, to chemicals. There's a lot of different things. The irritant contact dermatitis is really accounts for about 80% of all cases of contact dermatitis, though. There's a delayed type hypersensitivity reaction with that are the immunological response to contact allergens that occurs in sensitized individuals. And one of the most frequent causes of the allergic type is from plants such as poison ivy, poison oak, anything in that type of poison sumac, a lot of those types of plants. How do you differentiate it from urticaria? While differentiating it from urticaria, where the rash occurs is almost immediately after exposure and it disappears within minutes to hours. So you may be able to see some dermographism on these patients and then it disappears immediately. When you're thinking about contact dermatitis, it accounts for about 4 to 7% of all the dermatology consults, and the hand is about 2%, and 20% of female patients will be affected at least once in their lifetime. And a lot of women who work in cleaning, such as housekeeping, or they do dishes all day long, they are more prone to get this than anybody is. So how are we going to manage these patients? First of all, we're going to look at what's going on with them. They usually have some type of a red rash, and that's about all they do present with. And that's kind of their cardinal symptoms. So we have to look at this and see where exactly it is and what we believe is causing the problem. The epidermal inflammation is seen in the acute contact dermatitis, and that has a rough red patch, but without the thickening and the discrete demarcation of somebody who has a psoriasis, where they almost have a plaque buildup there. The acute lesions may be weepy, or they also may have numerous little tiny vesicles that have a little bit of an erythemic base to them. The lesions in non-allergic and that delayed hypersensitivity contact present in a similar fashion, but the distribution and the lack of the history of the atopic history is the most helpful when you're trying to differentiate between the two. If we think about managing these patients and how we're going to manage them, looking at diagnostic testing, you can do a KOH, prep on these patients. You can do a microscopic exam for tinea, but it could do some viral cultures, but usually not necessary. So usually the lab tests for these are done at the specialist office, maybe the allergist, and they do patch testing and they try to figure out what's actually causing a problem. In some patients, you could do a CBC with a differential, which would show you if they have any eosinophilia. But neither of this is really sensitive or going to give you a diagnostic picture. So when we manage them, we're looking at the treatment of contact dermatitis. We're trying to provide symptomatic relief to the patient, identifying that allergen, trying to get rid of that allergen, and then, trying to give them some symptomatic, relief. So using cool, wet compresses on them. Calamine lotion works awesome. Alpha Cari lotion works awesome. Using antihistamines for the itching works very, very well. And for the localized ones, a Burroughs aluminum also in addition to that calamine. But if the treatment's necessary beyond 2 weeks, then you may need to go into maybe some steroid creams, like a topical corticosteroid ointment or cream for about 10 days. So the triamcinolone works very well because it's lower potency for the face and the groin, and then you may need to get into oral systemic steroids if it's indicated in acute and severe cases, because then they'll get some relief for at least 12 to 24 hours. The high doses of prednisone can be given for up to 2 weeks, and you want to wean them down off of them, obviously, when you're doing that. But topical antibiotics, only for systemic infections would you go ahead and treat them with a topical antibiotic, because it is not going to take away the actual dermatitis itself. And this is a picture of an appearance of poison ivy, which is one of the contact dermatitises. Next, we're going to look at seborrheic dermatitis. And seborrheic dermatitis is one of the most common skin conditions that you will see in primary care in adults as well as in the elderly patient. And it's a chronic condition, and they get remissions and they get exacerbations. It commonly manifests in patients with HIV, but you don't necessarily see it just in HIV patients, obviously. It affects about 2 to 5% of the adult population. It is familial, and it does have a known genetic component. So this type of dermatitis was originally defined by excess oil secretions from sebaceous glands, and it was found in certain areas such as the scalp, the face, the chest, the upper back, and in the flexures of the arms. But then skin biopsies did reveal that there was some type of parakeratotic scale that was around hair follicles. And so this is it's not really known whether this occurs in response to infections, by skin fungi or vice versa. So the cause is only really partly known. There is an immunological reaction to it, which is called malassezia. And malassezia is colonized by affected individuals. And that's where these number of these organisms are found on the skin surface. And so it's like a fungal type of a reaction, and the fungal specific stains of the affected skin revealed that there are a large number of these spores within the uppermost skin layer. These are thin and ill-defined. They're almost like a salmony pink plaque with a yellowish scale to it. They're usually asymptomatic when they come in to see you, but itching is probably one of their biggest complaints. Each of the patches is surrounded by that erythema, and the borders are poorly defined, and the scales on it could be greasy and also appear yellow. But the most frequently involved area that you're going to see this in is on the scalp, and they complain of having a type of a dandruff. And this is a really good picture of seborrheic dermatitis that's on the chest wall of someone. When we're looking at these, the diagnosis is really based on your clinical finding and histories, and the dermatologists and allergists will do further testing on these patients by doing the RAS testing and testing for the malassezia furfur, which is and they go ahead and use that antigen-specific skin prick or do a RAS with them. And they also may do some methenamine silver stains as well to identify if there's any hyphae or spores there. When you're thinking about managing these patients, mild to moderate cases don't seem to bother patients, especially the elderly, but the younger people may. So they may need to use over-the-counter dandruff shampoo. There's also some prescription shampoo, such as Nizoral shampoo, that can be used. A topical corticosteroid may be necessary when there's a lot of erythema present, or even some the hydrocortisone 0.5 up to 1% for the face. And then ketoconazole, if it does have a fungal appearance or fungal, defined as fungal by doing the scrapings. But once the symptoms resolved, usually maintenance therapy is just required 1 to 2 times a week. And because there is a very strong association with HIV and AIDS, then treating that underlying infection if they do have that problem. And usually those patients are being treated by infectious disease anyway.